Welcome to Progenesis Academy webinar series number 3. We're very happy to have such a wonderful speaker today and a great panel. And the first 30 minutes, our speaker will be talking about contamination, cross-contamination, and infection risk of cryopreservation due to COVID-19. Then after that, we're gonna have the panel that will last about 30 minutes. And then after that, we will have a panel discussion that will be somewhere between 30 minutes to 45 minutes. Within this time, we will send you guys some questions or questionnaires to get some polls results and feedback. And at the end of the session, we will get your questions directly to our panel and our speaker. Let me start by introducing Dr. Kim Pomeroy. No need for introduction, very well known in the embryology field. Dr. Pomeroy is the scientific director for the World Egg Bank. Interestingly, he has been during his thesis, he has worked in molecular biology department in the Salk Institute and has been exposed to virology. So he has some very interesting perspective to bring into this discussion. Today, Dr. Pomeroy will be talking about contamination and cross-contamination and infection risk of cryopreservation due to COVID-19 epidemic. Without further ado, I will give the floor to Kim. Kim, the floor is yours.
Thank you very much. I'd like to thank Progenesis and Dr. Rock for this opportunity to converse with and interact with my colleagues. As he's mentioned, I've had a love for virology in graduate school where I took several classes, and also at the Salk Institute where I was a molecular biologist, and I was using viruses at that time to transfect cells and to make a cell line so that it would survive for many, many passages. But the topic of this, I know everyone has COVID-19 on their mind. There's a lot of concern. I just got off of Mavericks, and which is on Facebook. It's a site for embryologists. And there's a big discussion about how they should freeze and store embryos during this time of COVID-19. And so I think I can answer some of these questions, I hope, or at least provide information. I'm more interested in providing you information so that you can make your own decision about what you want to do based on the risks that you see. So we had a recent discussion related to this topic with the International IVF Initiative at ivfmeeting.com. If you want to go there, and I think it was the 4th session where we talked about this in detail. And we had a couple of virologists on the panel, and it was a very good discussion, but I don't think we really got to the specifics, which I hope to get to here. First of all, I'd like to give a couple of disclosures. Number one, I am in my RV in the middle of nowhere. So if at some point my audio becomes poor, let me know and I'll repeat it. Second, I am the science director for the World Egg Bank. I am also a speaker for Fujifilm Irvine. I'm on the scientific board of Art Compass. I want to talk about just a couple of quick definitions, because when we had this discussion on this forum that we had about, I think it was about 2 weeks ago, it seemed like there was some confusion, at least. Embryologists were very worried that there was even one virus in their media, and they want to know how they could have sterile liquid nitrogen and to have sterile storage so they didn't get any cross-contamination. So contamination is the presence of a microbe in an area where you normally don't expect to be it, especially in something like a sterile environment. Cross-contamination is, for example, if you have something stored in liquid nitrogen and a microbe goes from a vial that's contaminated with a virion or a bacterium and then it gets into another vial and cross-contaminates it. Infection is totally different. Infection is a very difficult process in most cases, and it means that the virus or the bacterium has hold up in tissue or in a person and is reproducing, and often is showing signs of disease. So first of all, I want to talk about what a virus must do to infect a cell. It's not real easy. You just don't have a virus and it automatically gets into a cell. First of all, you have to get the virus near the tissue. And to do that, it has to overcome a lot of the body's defenses against viruses and against other microbes. This usually means you have to have a large number of them. Second of all, it then will bind only to a cell that has the correct type of receptor. For viruses, each virus has a different type of receptor that it binds to. For example, the HIV virus, it needs two receptors. It needs the CD4 receptor, which is found on T lymphocytes and macrophages, and then it needs either the CCR5 receptor or the CXCR4 receptor. So it needs two. So there are sometimes also cofactors. The influenza virus, its receptor is a carbohydrate that's very common, sialic acid. Now, if we're mainly concerned with SARS-CoV-2, which is the COVID-19 virus, for it to get into a cell, first you have to have enough of the virus to overcome the body defenses. And it binds to what's called the ACE2 receptor. And the ACE2 receptor is involved in regulating blood volumes and blood pressure in the body. And so it must have this receptor. If, for example, this is a cell that doesn't have the receptor, the virus is not going to get inside of that cell. Once it binds to this receptor, it's actually the spike that binds to it. It needs a furin enzyme that will go ahead and cleave that spike in two, and that will then allow the SARS-CoV-2 virus to get into a cell. So it's nothing that happens automatically, and that's why most of the viruses that we know of only infect certain types of cells. Once it infects a cell, then it can take over the cell's machinery, and it uses almost all of the cell's machinery in order to survive and replicate itself. And it will make tens of thousands of virions, those are replicants of the virus, and then it will finally lyse out of the cell. When it lyses out of the cell, oftentimes it will coat itself with the cell's membrane. And this is what is often referred to as the virus envelope. And it is this virus envelope which is what we are destroying when we wash our hands in detergents, when we put alcohol on our hands, when we use hydrogen peroxide. It's that envelope, and that envelope then renders the virus so it's harmless because it doesn't then have the spikes to get it into a cell. So here's some information I'd like to show you regarding SARS-CoV-2 and what we know so far. First of all, there's no evidence of sexual transmission. You can't get COVID by sex unless maybe you sneeze on the person. The embryo and the oocyte have a barrier to many microorganisms called the zona pellucida. And this has been shown in a lot of research that's been done mainly in cattle. Third, it's not likely that there's an ACE2 receptor on eggs, sperm, or embryos. There's no regulation there of blood pressure, so it seems unlikely that you would find an ACE2 receptor on the zona pellucida or on eggs, sperm, or membranes. Now, you might find them on ovaries for some reason, or you might find them in the testicles maybe. But most likely, SARS-CoV-2 is not going to be spread by eggs, sperm, or embryos. And I would stress in particular eggs and embryos. I know there's some recent papers that have just come out that look at they look at a library. It's like an expression library to see whether there are things that SARS-CoV-2 has and if they are found in embryos. And they have said that yes, in this expression library, they find some elements of SARS-CoV-2. That's still doesn't mean that you're going to have the receptor there. And also the reliability of those analyses really depend on how pure that library was designed. Did they get rid of all cumulus cells? Did they get rid of sperm so that they're only looking at blastocysts, as this paper claims? The biggest risk, though, is going to be to our patients of infecting a healthcare worker or a healthcare worker infecting a patient. That is what we really worry about and must protect. There's also some danger if a patient gets pregnant and then gets an infection, because it may affect her unduly and it could potentially have an effect on the fetus. So how do we get these viruses and these bacteria? Don't we work in a sterile environment? And I would like to say, first of all, we need to remember we don't work in a sterile environment. And this is not a new situation. We have microorganisms growing in all of our laboratories. We do not work in this sterile environment. Our benches are not sterile. Our incubators are not sterile. The gases that we use in the incubators are not sterile. Our cultures are not even sterile. Our storage tanks are not sterile. And I even doubt whether the media we use to culture embryos is sterile. Just because you don't see anything growing in your cultures like this one here that has bacteria growing does not mean that you don't have anything growing in it. So we need to remind ourselves that our body contains 10 times more bacterial cells than human cells. We are more or less a transport system for bacteria. We're more bacteria than we are human. And no one's done analysis that I know of the amount of viruses that are in our body. Our skin is colonized with carpets of Staphylococcus epidermidis and Corynebacteria. Every minute, 30,000 to 40,000 skin cells fall off. And every month we get a whole new dermis. If you're looking in your laboratory and you're sweeping it up and you see these dust bunnies, a good portion of those dust bunnies are made of bacteria that has fallen off of our skin. The air that we breathe also has a lot of microbes in it. The air has 10 to 100 what are called colonizing units per cubic meter. And over 60% of these are gram positive. What about the air indoors? The air indoors is actually 10 times dirtier than that of the outdoor air. So how are you going to get this infection in you or a virus in you? It's everywhere. We've been dealing with it all the time. Have you been worried about whether you have Hep B or Hep C viruses in your liquid nitrogen tanks? They may be in there, because we do know from many studies that there are bacteria and viruses that are in the detritus in the bottom of our tanks. But I'd first like to point out that we don't work in a sterile environment. A great study was done by Cottle in 1996. Cottle et al. Looked at 30 IVF cycles, and they looked at different stages of the cycle, and they looked at them by taking swabs of media and rubbing it on plates and culturing for either aerobic or anaerobic bacterium. Their media, this was a while ago, had penicillin and streptomycin in it, in their culture media. They swabbed the vagina with culture medium prior to aspiration, and then they did one punch per ovary. They didn't go in and out of the ovary. And then they cultured for bacteria. And 50% of their cycles had some contamination. And I would say that is a gross underestimation, because what they will only find is what the media would culture. If they would have used a more modern method, which wasn't available then, of looking, for example, at some of the RNA sequences that they could tie to specific bacteria, I would guess they would find many more. 13% of the semen was positive for microbes. 27% of the follicle aspirates were positive for microbes. And I'll show you in a while, this is a very big underestimate. And 7% of their primary cultures, these are their cultures 20 hours after insemination, were still positive for microbes. Most of these microbes were non-hemolytic streptococci and Staphylococcus epidermidis. Those are the most common one. But they also found some ureaplasm, which to me, I would guess is probably found in all of our cultures. The reason is it's very common, it's very difficult to detect, and it grows slowly. But it does have an effect on the expression of genes, and we know that it can affect a lot of cells. So it's something that I would guess we have in a lot of our cultures. The other reason we probably have it is because it can get through a 0.2 micron filter, and that is the size of the filter most commonly used to filter media. Even after swim up, 5% of the semen cultures were still positive. Now here's something that I find very interesting, and this is looking at follicular fluid. We would assume that it is sterile. This is a study done by Pelzer and Knox in Australia, and they looked at 263 women. They did a culture system also, where they cultured the follicular fluid that they retrieved, and all of them had bacteria found in them. They also cultured organisms from the vagina, and the interesting thing was 71% of the bacteria that they found in the follicular fluid was found in the vagina. This may mean that, you know, the source of this bacteria may actually be, as you puncture the vagina, you contaminate the follicles. And I talked with Christine Knox one time, and she told me that she felt that if women came back for future IVF cycles, sometimes you would still find bacteria in those follicles that were probably the result from prior sticks that had gone through into other areas of the ovary and had contaminated other parts of the ovary. Antibiotics that we have in our media are not sufficient against all microorganisms. Most of the media that we have just has gentamicin, and it is mainly effective against gram-negative bacteria. But there are fungi. Pelzer and Knox found a lot of fungi in their cultures, and there are gram-positive bacteria in the cultures. Even the amount of gentamicin that's in this media, I think normally it's about 100 micrograms per ml of gentamicin, and that's not adequate to even kill a contamination of, for example, mycoplasma. So why are we worried even about something like cross-contamination? Meaning, if you have store a sterile vial, if there is such a thing, with tissue in it, with a non-sterile vial, that whatever in that non-sterile vial may get into the sterile vial. Well, the biggest study that came out was one by Tedder et al. In 1995, and they looked at bone marrow bags that were stored in liquid nitrogen. They all of a sudden saw that certain transplant patients were infected with Hep B virus, and when they sequenced this virus, they found that these ones that were originally not Hep B positive and that had converted to Hep B, that it came from one bag that was in that tank. So this put the fear in all of us that here's a way that we can contaminate vials potentially from someone that has a disease that we don't know about. But we have to remember that bone marrow storage is different from egg and embryo storage. They're not stored in vials. You see these large ethylene vinyl acetate bags. I think they hold 30 or 40 mLs of fluid. And you can see here, there's a little crack in the side of that bag where a lot of cells, a lot of blood can escape and can contaminate maybe other bags that are also split open. So if we want to really look and find out what is the chance of getting a bacterial or viral infection from tissue because it's been frozen, or that it can be transferred on to a recipient, we should look to the livestock industry, because there's a wealth of information in the livestock industry, especially with cattle. The cattle industry depends on the safety of ART procedures. In fact, the International Embryo Transfer Society has a manual out, and one of the methods if you want to export tissue, say embryos or eggs, to another country, is it has to go through a very stringent dilution procedure. And this is a way that is used to even treat infected embryos. So they work with tens of millions of bovine inseminations a year. There are almost 1 million embryo transfers done a year. There's thousands of imported livestock embryos. And worst of all, there are 3 big diseases that affect the industry. The most important being bovine viral diarrhea virus that is rampant, that you can find in a lot of slaughterhouses. Second of all, bovine immune deficiency virus and bovine herpes virus. So people have looked at these. There's a great review by an author by the name of Stringfellow that's looked at these to see whether or not you can pass these on to recipients if, for example, say a donor has this virus, or if there's a contamination, can it be passed on to the embryo? So one of the biggest researchers in this area is the Canadian by the name of Bielansky. And this study was done where pathogen-free embryos were stored for 6 to 35 years in the same tanks as embryos that had that came from cattle that either had BVDV or had bovine herpes virus 1. And when he looked at all the pathogen-free embryos, he found no evidence for cross-contamination. So this is one of the best studies that was looked at in a realistic situation, not an artificial situation. Here's an artificial situation. Once again, Bielansky et al. They looked at these 3 viruses in very high titers added to liquid nitrogen, and they had embryos that were in open and closed straws, so they didn't seal the straws. And when they looked at it, they found BVDV and BHV in embryos in some of the open straws. I think it was about 25% of the open straws. They found nothing in any of the sealed straws, and they never found BIV in any of the straws. So it shows you that, yes, if you do have a large concentration of viruses in liquid nitrogen, it can get into an open straw. But there are some viruses that appear to not be able to really do this cross-contamination. And one of those is this, this bovine AIDS virus, BIV. Another study that was very interesting that was done, this is an experimental condition, but that showed that you could not get cross-contamination, used mouse hepatitis virus and P. pneumotropica virus in cryovials. So they had large concentrations of vials. And then they put them in with mouse embryos in cryovials. And they left them there for 1 year. Then they did a thaw and transfer, and they had no infection of the recipients, nor did they find any virus in nitrogen. And we all know that cryovials don't necessarily seal very well. They do not always seal tightly. And we know that because sometimes we take them out, and when we warm them up, you hear them hiss as the liquid nitrogen comes out of a cryovial that did not seal well. Finally, one of the best studies, one of the ones that I think really looks at can embryos act as vectors for diseases, was in a real environment, was a study done by Anna Koba in 2012. And she had frozen embryos from HIV and Hep B or Hep C patients. Some of these patients had very high viral loads, over 2 million copies per milliliter. And she stored them, and then afterwards she looked at the follicular fluid, the culture media from these patients, and the liquid nitrogen used for storage. So when she retrieved embryos from these patients that were infected, she found no evidence using PCR of the virus. She looked at culture media, found no evidence. And when she looked in the liquid nitrogen where the embryos were stored, could not also find any evidence of these viruses. So this is a kind of a real analysis of what happens during IVF, and at least for these 3 viruses, whether or not you could find not only cross-contamination, but could you find contamination in the culture media or the follicular fluid, which then would lead you to believe that it could be on the embryos. So I think 2 things we've looked at. One is there's been no evidence in a real life situation of past cross-contamination, except for the Tedder case where a different cryostorage system was used of bags for bone marrow. What I think is also important is we should look at whether even eggs or embryos can act as disease vectors. I think semen and sperm, they can act as disease vectors. We know that. There was a case in the early 80s of men that had HIV. Their semen was used for inseminations, and it got passed on to recipients of the season. I think the probability was like 14% for each insemination that they would then become HIV positive. But let's look at these others. There are 6 separate studies that have been done from 1982 to 1990. I don't know, want to list them all. They've looked at several viruses in cattle: Acabane virus, bovine leukemia virus, blue tongue virus, BVDV, and foot and mouth disease. And they were never, when they had these deliberate exposure to bovine embryos, and then they washed them, they froze them, they thawed them, they couldn't find pathogens in the embryos. When they transferred them, none of the resulting calves or recipients became positive for these viruses. So it's very difficult. I mean, this is looking at tens of millions of bovine inseminations per year, 1 million bovine embryo transfers per year, all of this information. And we still haven't been able to find an incidence of either cross-contamination or embryos as vectors. So there are some reports of contamination and infection, and everyone should be aware of these. So there are 2 bovine viral transmissions reported, but these were traced to contaminated culture serum. They did not come from the embryos, but a serum that was used that was contaminated with the virus. In humans, there are 2 cases, all from one IVF clinic, where patients that were Hep C negative became Hep C positive after IVF. But they were able to trace it, that it was not due to the IVF lab procedure, and that it came somewhere during the ancillary procedures within that clinic through blood draws or something related to that. So why don't we have embryos and eggs causing infections from viruses? First of all, it may be because the pathogen can't bind to the embryo or can't bind to the zona pellucida. It could be that even if someone has an illness, that virus does not get into the follicular fluid or into the ovary. A big thing, I think, could be because of the dilution of the pathogen during embryo culture. We do a lot of diluting. We don't do it on purpose to avoid pathogens, but because we keep on taking this 1 microliter that contains an embryo and putting into maybe a 25 microliter culture drop, we do that several times, then we're reducing the titer of that pathogen and we're reducing the viral load so low that maybe it can't cause an infection. Or it could be that these cells don't have any receptors. Without receptors and with dilution, there's not going to be an infection. And the other thing I think we have to look at too, and this is a study done by Bielansky again, the zona pellucida is selectively permeable. There are only certain viruses that have access to the embryo. And we would guess that there's a lack of receptors for these viruses that make it such the virus might be around in the media, but it gets diluted out. It doesn't bind and it doesn't infect the cells and get inside of the cells. So one of the best methods that we use in IVF and in livestock industry to prevent contamination is dilution. And one of our colleagues, David Battaglia, did this mathematical study where if you took 1 microliter with, say, your embryo, your egg, and put it into a 25 microliter drop, and then during culture, if it went through 1, 2, 3, 4 passages, that's a 1 to 1 million dilution. Then if you went ahead and vitrified it, you had a 1 to 6.6 trillion dilution. And this doesn't then include the dilution steps that happen when you warm it. But what we can know from this is if you have concentration of virus in solution, by the time you've done a 1 to 6.6 trillion dilution, there is literally none of that virus around. So I think one of the big things we need to recognize as we're trying to decide what should we do in this case today with COVID-19. We need to realize the virus needs receptors. We don't work in a sterile environment. There's never been an evidence for cross-contamination with embryos or ova. Ova and embryos are terrible vectors for viruses, and there's been no case shown where an ova or embryo that I know of has served as a vector for an infection. And one of the big solutions is dilution. That helps reduce the odds of contamination. So what should we do to handle the risk for contaminations with SARS-CoV-2? First of all, what about the same thing we've done in the past for sexually transmitted diseases? And SARS-CoV-2, as far as we know, isn't even sexually transmitted. And that is, we go ahead and we store them in liquid nitrogen tanks. If we feel there is some risk, then we store them in a separate nitrogen tank. But we make sure we do our dilutions. I think if you want to be ultra conservative, you could quarantine these cryopreservation tanks. But I'd ask you, why aren't you doing that in all of your tanks? Do you test all of your patients for all known viral diseases, for influenza, for example, or measles? We don't, and we don't store those embryos in different tanks. And we have no reason to believe that they will infect the embryos or the eggs. Finally, I'd like to say that some people have mentioned the use of, and this came up in one of the conferences we had, the use of vapor storage tanks. I'd like to remind everyone, vapor storage tanks are meant to reduce the risk of cross-contamination only. And even though those tanks, I think as such, are dangerous tanks to use, as evidenced by one of the failures that happened that was very publicized of a cryo storage tank, was a vapor tank. And I think the weaknesses of the vapor tank are the potential failure of a solenoid or a device that is delivering liquid nitrogen to that tank, and that the amount of liquid nitrogen in those tanks is a very low volume, which gives you very short amount of time to recover from any sort of failure of that tank. And in fact, Stan Lebo, in one of his many articles, said that vapor tanks place the specimen in a somewhat more precarious situation in that they may be subjected to unintended and inadvertent warming to temperatures above -130°C, the glass transition temperature of ice. Incipient damage to the cryopreserved cells by recrystallization may result, but it may not become evident until months or years later when the sample is thawed. The problem is that such slight damage is cumulative. Each incident of warming above -130 will contribute to decreasing functional survival of cryopreserved cells. I thank you much for your attention. I would like to remind everyone to keep safe and continue to keep safe. We're not over this yet, but I think that we don't have to worry probably as much as most people have thought of originally regarding cryopreservation in this time of COVID-19. Thank you.
Thank you so much, Kim, for the very interesting presentation. I would like to introduce the panel, and maybe we can get started on the discussion. Kim, you're going to be staying with us, correct?
Sure, yes.
Perfect. Okay. Well, let me make an introduction of the panel. We have a really, we are really lucky to have such a great panel. We gonna be starting the introduction of first Debbie Venier. She is a senior embryologist and lab supervisor in La Jolla IVF Center, Fertility Center. Debbie has given a lot of training at Illumina and other places, and she's very well involved in the IVF community as a speaker and also as a trainer. We have with us Dr. Anderson. Tony Anderson is a multi-center laboratory director for Aspire Fertility. He's also the founder of and the director for Embryo Director IVF Academy. That's a program, a training program. Maybe we'll have a little bit of time to ask you about that program later on during the session. And we have with us Ali Ahmady. Dr. Ahmady is the laboratory director for USC Fertility. Thank you so much for joining the panel. Let me ask first, the first question I'm gonna ask it, and it's for all of you. Now that we have seen the presentation, the Kim presentation on COVID-19, are you concerned about it? Tony?
Most of my experience has been with very similar to Kim's presentation. I know when I was in the bovine world, we had to do a lot of trypsinizing of our embryos, and if we were doing any international shipping. But really, I thought it was interesting. I'd never seen the report where the 35 years contamination, looking to see if there was any in the embryos. That was a great discussion. We are also in our Aspire Prelude network talking about should we freeze in separate tanks, and I really don't know why we would do that. If we go and change our protocols today for this, how are we going to handle future viruses or things like we have? The FDA doesn't require us to separate those out. They just have us separate them into separate quarters in the tank. And so I think we should follow those guidelines that the FDA is giving us to date.
Fantastic. Debbie, can you please give us your inputs?
Yeah, to some degree, but I thought it was interesting how Kim started his talk, and he said where there's more concern is in the transmission of patient to staff or staff to patient, as opposed to within the embryo world. And I totally agree with that. I'm more concerned at are we as staff members in the lab going to be bringing this in, as opposed to it being transferred from embryo to embryo. So I thought Kim did a really good job explaining how highly unlikely it is for there to be transmission within a cryo tank or within a culture system because of so much dilution. I've never seen that math done, Kim, so it was kind of cool to see the 1 to a million and 1 to a trillion by the time we're done getting the embryos through their culture system and ready for freeze. So that math was very kind of comforting, like, oh, okay, our embryos are going to be okay. But so then my concern kind of goes to the staff and the patient. I tested positive for COVID-19 3 days ago, but was I exposed to it in the meantime at the grocery store? And now I'm bringing it into the lab and exposing patients in pregnancy. So I think the next step, obviously, is, what's going to happen if we're transferring these embryos healthy, but the patient was exposed potentially in our office. What's going to happen then? So I definitely have concern, but definitely am more comforted by what Kim had to say about transmission within the laboratory.
Fantastic. Ali?
Sure. No, we are not. I personally not concerned, because if the patient doesn't have any symptom, the test also is either not done or not positive, then we shouldn't be worried about it.
Okay.
And as Kim also mentioned that, are we concerned about everything, every viruses out there? We are not even testing for every viruses anyway.
Yeah, very good. So, yeah, so one of the latest publication on the expression of EC2 receptors on embryos, the Colaco and collaborators, and one of the one person has put a link here in this discussion, also about a expression of angiotensin receptors in sperm. What do you guys think about these two publications?
I just looked at, just as I was listening to Debbie talk, as I was looking at this article that is by Marta Gianzo, and it looks like a very good article. It was published in 2015, And not only did they look at expression, which I think, you know, that's interesting, but in that article, which I briefly read, it looks like they also looked for localization of the receptor on spermatozoa, which to me is the real test. So sperm may be susceptible to the virus, assuming they could get through the blood-testis barrier.
For the embryos, it was just an RNA expression test. It was not testing for actual receptors. Rather, they were just looking at the expression of angiotensin, right? On an RNA level. Okay. Ali or Debbie, are you guys? Do you guys want to add anything on the two papers?
I'm not really familiar with it.
Okay. Maybe we can share those papers with you guys at the end of the presentation.
Yeah.
And then we could have another follow-up. Tell us a little bit how your lab is currently operating, Debbie.
So we're in the process. It's a transition for us every day. We're kind of changing what we're doing, but you know, we currently are trying to minimize. We've been shut down for a few weeks, but we're starting to start the process of opening up. And what are we going to do when we open? And how many patients are we going to allow in? And we're going to minimize patients waiting in the waiting room. We're going to, obviously, most of our staff are going to be wearing masks and gloves now that they didn't used to. And we're requiring all of our patients to wear masks and gloves. And we are starting with COVID-19 testing, infection testing of all patients that are coming through. Granted, they test negative, but we feel like we have to do our due diligence and try. And then once we have that negative test, actually from their day of testing, we're having them quarantine until their procedure is done. So they're going to get tested on Friday, and even before we have results, they need to start a full quarantine so that we can at least make an effort to be sure that our patients that are coming in are negative. We are planning to also test all of our staff as well. We have antibody tested our staff. Not sure how accurate the antibody tests are that we got, but we tried. But when we do have a more accurate antibody test, I think we'll probably try that as well. And then infection tests to some degree. Not that we know that that's the right thing to do, but we feel like we have to make some effort. We're having all of our patients that will be coming through, if any are coming through in May, they'll be signing consent, understanding that, you know, these are the guidelines. Right now, we do not have information on early pregnancy and coronavirus. We do know if there's vertical transmission in early pregnancy. We've seen a few of those studies coming out in late pregnancy saying that there's no vertical transmission. There's no this virus have any of that information. So it's tough communicating to the patients because they're in their little warpath of I want a baby and I don't care about anything else. And we want them to have a baby too, but we have to care about everything else. And it's hard to kind of find that happy medium. And I know clinics are kind of all over the board as to who's seeing patients, who's not, who's starting up, who's not, who never shut down. And, you know, what's right or wrong, I don't think any of us really know. But we just feel like we really have to protect our staff and we have to protect our patients to the best of our ability. So.
Very good. Thank you so much. Tony, can you tell us a little bit about your experience with the COVID-19?
Yeah, ours is very similar to what Debbie just described. And I think most everybody, even everybody in the audience would say, we just don't know exactly. We're kind of making this up as we go. And so these forums like this are great resources for us to learn from each other in large groups versus just, you know, small sessions with our friends and things like that. But, you know, as we're starting up, we're kind of looking at what Italy has done. Italy kind of was ahead of us, and, you know, separating into two teams. We'll probably go out into longer days. I'll probably break my teams up into 4 10-hour days a piece to keep them separate. I always say we're going to clean our lab like it was a crime scene. make sure that every day when we're done, we're not leaving any virus behind. I'm not as I think Kim pointed out that, it could be in the seminal, that it's really not in the sperm or the egg that or the embryo, but it could be in the follicular fluids and the ovaries, and the seminal fluids, but we should all be using personal protective equipment. So the real risk is patient to patient, the employees to the employees and employees to patients, vice versa. So we're trying to keep that separate distance. We're going to do our retrievals probably instead of every 45 minutes, every hour and a half. Limit the number of starts we have each week till we know we can find a groove of how that goes. We're going to do drop-off sperm samples, kind of curbside samples. We're going to actually go outside and get the samples from our patients when we can. We haven't talked about doing a lot of the antibody testing of our patients because, we don't know how accurate that is. One of the things I'm personally recommending is that we create a type of consent or because somebody may get the virus after the retrieval. I know NYU has suggested testing at the time of gonadotropin start and at the time of retrieval, but you could get it, you could have the virus and it could be dormant and not know it. So, we don't know what's going to happen with the virus. And if we have a pregnancy, we're going to know here, in some months. But, if we freeze these embryos, we need to kind of know by the time when we do the transfer if there's going to be any problems. So some sort of consent to realize that did they have the virus between retrieval and the time they were frozen, so that we'll have some history to base our data on.
Very good. Thank you so much. Ali, can you tell us a little bit about your experience?
Sure. We are not completely shut down. We have minimal staff on board, as we do have some cancer patients for sperm freeze, egg freeze, sometimes embryo freeze. So we do all precautions to make sure that, we are not contaminating any or, patient even. Those patients coming on board, we make sure that they don't have any symptoms. We are not doing any tests yet on them because they're not available tests so far. But we do everything we can to make sure that we provide those services for those patients who are in need, especially cancer patients.
Very good. Thank you. Thank you so much. Kim, can you tell us a little bit about your experience?
Well, we're basically totally closed right at this point at the World Egg Bank. We're getting ready to start up this next month, but it was a time when we felt we should wait and see what's happening before we went forward. One thing I'd like to address, though, is I failed to, first of all, recognize that, and one of my co-authors is here listening to this, Stan Harris. He didn't remind me of this except I saw his name, and we've covered a lot of the issues that I've talked about here in a paper that we wrote for fertility and sterility. I'm the main author, and then there's about 6 other co-authors regarding the risks of cross-contamination. And I know that someone has asked the question about whether you should use sterile liquid nitrogen. And a lot of people think this is an obvious way to go, but you have to realize the current method to sterilize liquid nitrogen that looks like it's going to be the most useful and the cheapest is ultraviolet radiation. And to do that, you have to stick it down where all of your specimens are, or you have to remove all the specimens and sterilize it after you've sterilized the tank and then put the specimens back in. That's really what you have to do because you don't want to damage your specimens. It would be very, very difficult to do. And every time you get moisture against the tank and it crystallizes and freezes, you're just recontaminating it. Every time you stick a device into that tank, you're recontaminating it. You can't keep sterile liquid nitrogen sterile.
Very good. And I appreciate that you're looking at the questions. I was trying to get onto the questions that are posted by the audience. We have a question from Enya Colasso. She asked, is it possible to find the virus in the seminal fluid? And if so, can the virus spread to a person doing the prep? We'll start with
we
you,
have
Debbie.
no idea.
Your voice is muted. Okay, perfect.
Oh, sorry. Yeah, I don't know.
Okay, Kim, what's your answer?
My answer is we don't know if it's in seminal fluid yet. It might be, but can it spread to personnel doing preps? If you're using universal precautions, then it can't.
Okay.
There is one report is indicating that there is no any virus in seminal fluid. It's, I think from China or something. Yeah.
Any other answer from?
They only look at 6 patients, so I'm not sure whether it's useful.
Anyone in the panel that wanted to add something about this question?
I'm with Kim. You should be using your personal protective equipment. You shouldn't treat samples that potentially have coronavirus any different than you would for hepatitis or HIV. You have the same risk of getting those as you would coronavirus, I would say.
Very good. And so the question that Stanley Harris raised, he was saying, if the dilution is the answer, what would you do about continuous culture? And what was your answer to that, Kim?
It does increase your risk, but you know, is there an increased risk from 1 to 6.6 million versus 1 to 1 million? It probably doesn't decrease it. You just want to make sure you've got a lot of dilution going on if you're using this continuous culture, especially if it's in these very small micro drops like you have in these systems for constant videography of the embryo.
Very good. What do you guys think about the staff? Should the IVF staff be tested for infection and for antibodies as part of the routine laboratory procedure in COVID time? Kim?
Well, I would think the only reason you really want to test is to see if they have antibodies that would protect you from a second infection. And I don't think we know that yet. So all you're being able to detect is this person has been exposed to the virus at some point. And you can't tell whether or not they have an active infection, for example. So what do? Most of these tests, and you know this, you probably should explain this, Nabil, because this is your area, but we don't have a lot of answers about the false positive rate and the false negative rate of each of these tests. Not only just the testing, often the testing is very good, but the sampling. I just watched my wife a couple months ago be tested for influenza, and the guy barely stuck the probe in her nose because she jerked her head back, and then he took it off and tested it and said, no, you're negative. So how you test it is just as important as what test you use. And we have to find out what is the positive and negative, false negative and false positive rates of these tests.
Very good. Debbie, what's your opinion about the testing staff?
I think if we test them and they're going to and from work, they could be, negative one day and 2 days later they could come back and be exposed. So it's hard to say testing is an accurate way to do it, even if the test itself is accurate. But I feel like we have to make some effort, especially with, I don't know, it's tough. The states are all different. I think if we were in New York, I would feel way differently than I do in California. I don't really know what the right thing to do is, but I feel like we have to try to do something. Yeah. And I think the market's going to be flooded really soon with COVID-19 infection tests, COVID-19 antibody tests. I think people are going to be really confused between the two, because some antibody tests are saying those are infection tests, and it gets kind of hairy. So I think everyone that's doing the testing needs to really understand which test you're getting and what that's telling you, and that in 2 days, that could be different inside your body. But you know, we are just trying to make some effort at this point. And so we are going to test our patients for infection and then have them quarantined just to try to keep our staff safe, knowing that, okay, we have a patient that tested negative that's here, they're quarantining themselves. And, you know, that's an honor system. Are they going to go to the grocery store on their way home? I hope not, but maybe. But we have to make an effort, and that's our effort. I don't know if it's the right thing to do, but that's the effort we're going to make.
Yeah, I think you're right, Debbie. Nothing's going to work 100% of the time, but
yeah,
we have to try.
Ali, what's your take on that?
Well, we always should be concerned about well-being of our staff. Our staff would be, you know, center point of what we do. We are relying on them. If testing give us assurance, give them assurance as well, why not?
Okay. Should cryopreservation be done differently?
No.
No. I think cryo is spot on.
No.
Very good.
Yeah, I agree. And I think someone had a question on, should we use slush liquid nitrogen? And I don't know where there'd be any advantage from that. Our cryo systems are actually very solid. Most everybody does really well with, particularly with vitrification. So,
you know, the one thing I did think about when Kim was giving his talk was, you know, we technically have closed vitrification systems now, but, you know, when we vitrify, I think most of us plunge with the straw open into the liquid and then we close the straw. I think most people do it that way. But I was wondering, well, how many patients do we often freeze into that same cup in the open system? And, you know, could there be this cross-contamination in that open cup before we actually close the system? Because we definitely freeze, you know, 4, 5, 6, 7, 8 patients in the same little bucket or cup or dewar of liquid nitrogen before our system is actually closed. But, Kim, your statistics are showing that really you can test the liquid nitrogen and you're not finding the virus in the liquid nitrogen, which is comforting. But I was wondering if we shouldn't have little separate cups of liquid nitrogen that we're plunging our open straw into when we're freezing and, you know, keeping that liquid that's exposed to the open embryo separate from our patients, because we don't currently do that. I don't know. Do you guys?
No, we don't do that.
You know, we don't. You know, listening to your comments, Debbie, and also there's been some discussions about UV for sterilizing liquid nitrogen tank, and Kim gave a great example of every time you put another one in there, it's contaminated. But you know, it scares me to death to put UV in my tank with embryos. I never understood. I just wouldn't want to do that. But being that we've had this discussion with UV, I've actually considered getting some sort of UV wand that I could maybe decontaminate maybe that pot that you're talking about between cases. There's no embryos in it. Could you then technically just kind of kill any virus in that? Could you do that to your, you know, your stations that you're working at? Not exposing it to any product, but exposing it to your surfaces.
Right. Kim, how about you?
Kim?
Do you freeze more patients in a little dewar at a time?
In a little dewar. We don't.
Well, whatever you're plunging into.
We don't, because by the time we're freezing vitrifying the next one, we need more liquid nitrogen. So, but we don't try to avoid not doing that. Let me put it that way. I don't think it's necessary. I think the livestock data indicates that even when you have a large amount of virus around there, you don't get it into the vials or the devices. But you're right, they haven't looked at necessarily just open devices like most of us use. And as far as freezing oocytes, I would not use a closed device at this time. There's not enough data to warrant it. But if you're concerned, my solution would be use one of the closed devices for blastocysts. I think the velocity of cooling and warming for blastocysts, there's a lot more slop that's involved in that. And you can have a lower cooling rate and a lower warming rate because the membranes are much more permeable. And so I think that therefore it's not as dangerous. No one's ever tried it yet, but someone should be able to look at it. And I know that there are a lot of closed systems out there for blastocysts. I just wouldn't use them for oocytes.
Very good. Well, we have asked the audience some questions and to have a poll so we can share with you guys and with everyone. Miriam is gonna give us some answers. Miriam, can you read the questions and the answers from the audience? Miriam, are you there? I think we have some technical issues. Riley, can you hear us?
Yes, of course. So I just, so I just launched the poll questions. So please allow some time for the audience to answer them.
Okay, perfect. So,
also, yes.
Okay, so let's wait on the polls to be answered. So basically, those questions are just asking the audience if they are currently operating, when they would be operating if they are not, and we ask them if this webinar has changed their perspective about resuming work. We also ask them about potential ways for screening patients. So while we are waiting on the answers, I would ask you guys to give us some advice for other embryologists that are now trying to start. What would you tell them and how they would proceed further in the next, when they start their lab, what they would do differently? And I will start with maybe with Debbie first, and then I'll go through the panel.
Okay. I wouldn't just go back to the lab like nothing happened. I would definitely try to recognize that our life from here forward, both professionally and personally, is going to be different. And I think safety for your staff and your patients as a human being needs to be first and foremost. And whether that's just adding some personal protective gear to the staff. I mean, our receptionists, our nurses, our medical assistants, and our doctors all now wearing a mask at all times. And we all hate it. We hate it. But it's going to be the way it is for the time being, because we have to portray to the patients that we are exhibiting as the best safety precautions that we can. And it's going to be a spectrum. I think some people are going to go, full tilt and change, the number of patients that are coming in the office, the number of cases they're doing, how many people are allowed in the lab, who's allowed in the lab. I think most labs already controlled that. I think we will probably control that even higher now. Where we're storing our tissue, are we going to be quarantining that tissue? That's another thought. I think a lot of the outside of the lab protocols need to be adjusted too. I think, how we're scheduling our patients and how we're screening our patients is going to have to change amongst, what's happening in the lab and how many embryos we're going to be handling at any given time. And I don't know, it's going to be a process for sure, and it will evolve.
Very good. Kim, what would be your recommendation to other embryologists that are in this uncertainty, trying to decide what to do next?
First of all, I think what Debbie said is right on point. And that is, there are things we're going to do because there's science behind it. And there are things we're going to do because it shows that we're trying to make a change and it looks good for our patients. And it's something that there might not be a lot of science behind it, but there might be some logical reason to do it. The main things that I would want people to get from this lecture is, I would say, look at the Anna Cobo paper that I mentioned. This is IVF in people with high titers of a sexually transmitted disease, viral disease. hepatitis B and C, and HIV. And when they collected those embryos, when they froze them, they were not at risk to patients.
Ali?
We already in operation anyway, not in full operation. So we have a system in place. We already have the staff, having a mask and protective equipment, everything. And also we have a system in place that in such way we clean and disinfect surfaces outside incubator in the morning and in the afternoon and whenever we touch. And when we are going to have cases, we are not going to have too many cases. Gradually, we need to increase the cases.
Any other inputs? Tony, do you have any advice for embryologists to?
I liked Debbie's comment where she said, we're evolving, and I think the way we're sharing things here is a great way to evolve faster. We're going to start out slow and steady, wearing the masks and all the PPE at all times is the new norm. But I think one of the new norms we're going to have in order to do the same volume, to keep the physical spacing that we need to have between personnel and our patients, is to possibly have longer days. And we tend to try to keep our weekends at a point where they are minimal staff, just doing the minimal work, starting our patients on gonadotropin so that they don't end up on retrieval on weekends. But to space things out, we may have to, I'm going to try to keep my team on 2 different teams where I have 4 days on, 4 days off, so that one, they're being able to work full time and we're able to still accommodate the patients over, just over more hours during the week.
Mm-hmm. We can't hear you, Nabil. You're muted.
Oh, sorry about that. So we're gonna go to the polls, and then we're gonna collect those answers, and I'll ask you guys what you think about it. So we asked the audience, how do you currently feel about resuming IVF lab work? 22% said very comfortable. 65% said somewhat comfortable. 14% said uncomfortable. We asked, did our webinar change your perspective about resuming IVF work? 41% said yes. 47% said no. 12% said not sure. We asked, for those who answered yes, what do you feel? Do you feel more confident about resuming work in the IVF? And 40% said yes, 3% said no, and 8% said not sure. So it looks like the webinar has changed the perspective in a favorable way, and that 40% of those who see this that way said that they would feel more confidence with this presentation. And we asked them, are you currently operating in the lab? The ones that are currently. So 25% are currently operating. 75% are not operating in the lab currently. And for those that are not operating, we asked them, when are you planning to restart? 17% said less than 2 weeks. 37% said within a month. And 16% said after a month. So it looks like the majority are gonna be within a month, 37. Add to that the 17, so that's approximately half of the participants. And we asked them, would you be screening the patients in any way possible? Number 1, by temperature or symptom. 79% said they will use temperature and symptom. 4% said they would not screen. 27% said they would do RNA RT-PCR for infection, and 25% said antibody, 10% said all the above. So it looks like the majority voted for temperature and symptom, and the antibody and RNA testing is about 50%, 52%. So what you guys think about the polls?
I think it'll be interesting to take that poll in another month and see where people are. I think it's so changing. It's rapidly changing right now, and everyone's kind of looking around. What's everybody else doing? We don't know what to do. So I think that everyone's thoughts and processes are really going to change in the next month, because I think a lot of us are going to be opening up in the next month to some degree, to varying degrees, but I think it's going to keep changing.
Very good. Kim, what's your feedback on the polls?
Well, I think it looks pretty good. I think it's, I think I'll take the opposite. I think if we would have looked in the past, it would have been a more dismal poll. And like Debbie said, as we look in the future, I think it's going to look a lot better. I think the unknown is always something that we're afraid of. The only thing we can use to calm that fear is to look at similar things that have happened in the past. Similar infections, similar viruses. We've gotten through them. They haven't had terrible results as far as on long-lasting results on economies. The unfortunate thing is that many people at the beginning of this are going to pay for it with their lives until we eventually have a vaccine or we get down to some sort of herd immunity.
Very good. Tony?
Yeah, just like Debbie and Kim said, it's changing ongoing. But one of the things I thought was interesting is about half the audience said that, this webinar has changed our perspective. That of those the half that did, do you feel more confident? And half of them said yes. So I think Kim did a great job showing that we don't have to worry about storing our embryos in liquid nitrogen. Our embryos and sperm and oocytes are safe, but that we can, through this process, we're going to, push forward. And I just say, we got to crawl before we run, and just, learn as we go and help each other out through these venues like this.
Yeah. Fantastic. Ali?
Sure. I guess as all the other panelists said, one of the main concerns for the lab was, cryo storage, contamination, and all this. So at least today they have a clear mind by presentation by Kim that, this is not real issue. And the other thing is also, since there are testings available so that patient can be tested, staff can be tested, this would be more assurance. At the end, economy need to work. If we continue and shut down the lab for a few months, all of us are going to be out of job too.
Yeah.
Very good. Well, I know that some of you are actively involved in training. Debbie, are you doing any workshops in the next few weeks, or how is it going?
Everything's been canceled. No plan.
No plan. Interesting.
No plans at all. Yeah.
Well, most people are going virtual. Isn't that a possibility?
It would be very challenging for me to train an embryologist virtually. I guess we could try, but I'm kind of a hands-on girl. I would have a hard time training someone. If worse comes to worse and that's all we have to do, we do it. But I think being there present is the ideal way to train somebody.
Yeah. Tony,
we're looking at the fall.
Very good. Tony, you have a training program. How are you planning to proceed? Are you planning to turn this into some sort of webinar type of training and guidance, or what's your plan?
Yeah, we I've thought about doing it on the webinars, and I'm like Debbie, the best way to do that is to do it repetitively over and over with hands-on guided instruction. I actually have some online stuff that I'm giving away for free right now that you can, at the IVF meeting website, I'm allowing people to go online to do those. You know, I'm hoping that once we can travel, that people will be able to come in. You know, the finances of that is actually challenging because right now programs just want to recoup from the losses they have. This is a great time to do some training like this. And, you know, most people are on furlough, and the way to really train them is to actually have them sitting at a scope. You could do some virtual training if they had access to a microscope. So as we're starting back up, that might be an opportunity to go to do that virtually, very much like a Zoom meeting, walking through the processes. You could actually watch people do the procedures and guide them and give them tips and suggestions on how to make small improvements.
Very good. I'm sure there will be ways for someone to train just looking at videos of how the, you know, or real-time biopsy on a conference call. Anything that you guys wanted to add before we wrap up the webinar?
No.
No.
Very good. Well, I would like to thank each one of you. I would like to thank Kim Pomeroy for giving us such a wonderful presentation. And I would like to thank Debbie and Tony and Ali for the you know, wealth of information we got from you guys and the guidance. I'm sure the IVF community will appreciate that. And I will like to thank Progenesis Academy for hosting this webinar, the third one. Next week, we will have another webinar, another speaker. So stay tuned, check your email. Thank you so much for attending, and I will see you next week.
Thank you,
Thank
Nabil.
you, Nabil.
Thank you for organizing this.
Bye-bye.
Bye-bye.